all of you. Today, our guest speaker for the day is Dr. Reena Das from Chandigarh. She's going to lecture us on uncommon hereditary anemias. This webinar is brought to you by Mumbai Hematology Group, supported by Sun Pharma and managed by Perfect Square. I thank Mr. Arvind Suri and Team Sun Oncology, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Priyanka Samal from Bhubaneswar, our guest speaker for the day, Professor Dr. Reena Das from Chandigarh, all our discussants who are themselves eminent hematologists and you participants preparing your Sunday morning, afternoon or evening. Next Saturday, that is on 18th of February, from 7 p.m. onwards, we have got an excellent webinar on histiocytic neoplasm from behind the scope, a primer on diagnosing different subtypes by Dr. Aishwarya Ravindran from the University of Alabama at Birmingham, Alabama, USA. And the following day, that is on 19th of February, Sunday, we have a lecture on modern antibacterial drugs in neutropenic subjects by Dr. Aisha Jamshed Sunawala from PD Hinduja Hospital, Mahim, Mumbai. Now it's a time to introduce all our discussions for the day, and we have a galaxy of them here displayed in alphabetical orders. To start with, we have Dr. Abhilasha Sampagar from JNMC Belgavi, Dr. Akshay Mandaloy Goel from TMH HBCH Varanasi, Dr. Amit Jain from Thalassemia Care Pediatric Hematology Oncology in BMT Center, Borivali, Mumbai, Dr. Arpita Gupta from LTMG Hospital, Sion, Mumbai, Lieutenant Colonel Dr. Ashok Meshram from INHS Aswini Kolaba, Mumbai, Dr. Hamza Yusuf Dalal from Fortis Hospital, Mulund, Mumbai, Dr. Jagdish Chandra from ESI Model Hospital and PGI MSR, New Delhi, Dr. Kunal Goel from Homi Baba Cancer Center at Tata Memorial Hospital, Varanasi, Dr. Nidhi Dikshit from Apollo Hospitals, Kolkata, Dr. Neeta Radhakrishnan from Postgraduate Institute of Child Health, Noida, Dr. Omkar Khankar, Consultant Pediatric Hematologist Oncologist at Bombay Hospital Institute of Medical Sciences and Assistant Professor at Department of Pediatric Hematology Oncology at TN Medical College and BYL Nair Charitable Hospital, Mumbai Central, Mumbai, Dr. Prashanta Bhatt from KMC Hospital, Mangaluru, Dr. Priyanka Agrawal from Institute of Medical Sciences, Banaras Hindi University, Varanasi, Dr. Prashanta Kumar Chaudhary, Consultant in Hemoglobinopathy dealing with thalassemiology, Dr. Ruchira Mishra from SRCC Children's Hospital, Mumbai, Dr. Shailendra Prasad Verma from King's George Medical University, Lucknow, Dr. Sujata Sharma from Lokmanya Tilak Municipal Medical College and Hospital, Sion, Mumbai, Dr. Suma TL from SCG Hospital, Bengaluru, and Dr. Urmimara Bhattacharjee from PGI, Chandigarh. Now it's a time to introduce our special guest for the day, my friend, my colleague, Dr. Priyanka Samal from Bhubaneswar. Dr. Priyanka Samal is MD, DM in Clinical Hematology, Professor and Head, Department of Clinical Hematology, Hemato-Oncology and Stem Cell Transplant at IMS and SCUM Hospital, Bhubaneswar. It's my privilege to invite her to inaugurate our webinar and give us some words of wisdom. Over to you, Dr. Priyanka Samal.
Yeah, thank you, Dr. Amit, and immense thanks to MB Agarwal sir for giving me this opportunity today, and especially to address this session for bringing about awareness for the hematology in India. So thank you, madam, also for the being speaker, and she was our teacher over here, Reena Nair ma'am. So to start with, I will not take much of time, but for the young hematologists who have been attending this webinar, I would say that hematology is a vast subject in itself, because this forum itself has said that since March 2020, when the COVID struck us, since then every Tuesday, every Saturday and Sunday, the webinars are being conducted by the MHG group under the aegis of MHG, as well as the pioneer who has brought about this webinar, that is MB Agarwal sir. And every time there are changes, and every week we see that some new thing we gain from these webinars. So just useless to say that how vast this subject is. And previously hematology was like people used to know that it is just a CPC which gives an idea about hematology. But apart from that, there is a huge amount of knowledge we have to have from two aspects. Hematology is not only just clinical hematology or a lab hematology. It is a combination of hematopathology, lab hematology, as well as clinical hematology. So from that itself, you can understand that when we have DM degrees for hemat path and for clinical hemat, it itself is such a broad and a vast subject that a person who enters this has to undergo a training for 3 months, 3 years, I mean to say. And apart from that, stem cell transplant. Now, the younger generation, they are very much interested to get trained for the BMTs or the transplants. So a lot of opportunities apart from that, CAR T cells, which are coming up therapies. And previously, when people used to think that once hematological malignancies like leukemias, one of the worst heard of cancers or felt of cancers by the patients, we have now so much of opportunities to cure these patients. So for the youngsters who are attending these webinars, do take part in the quizzes so that you gain interest, you have knowledge, and that is what I have seen. In my experience, I am now the professor and head of the department of hematology, and we have started a DM course curriculum in our hospital. So there are 2 DM seats as of now, and the first batch will be coming out now. So what we feel that these students, they are very enthusiastic, and most of them have attended these quizzes which we conduct. So that is how an awareness is brought among these students. Otherwise, the other subjects like neurology, cardiology, they are there since a very long time. Medical oncology, hematology, these are new subjects. Immunology, these are new subjects. But I would say that hemat itself is a vast subject, and consultative hematology is again a very important subject. So for the youngsters who are dealing with hematology, it is not only that you gain experience regarding what is there for the hemato-oncology, but the benign hematology or the consultative hematology, it is definitely much more brainstorming rather than these oncology part. So today we have definitely with us Reena madam also, who is pioneering her subject like the hereditary anemias. If we look into sickle cell and thalassemia, there is a huge burden in India. So the subject is not small at all. Its visibility needs to be increased. We need to be more practical and more scientific in our approach so that every patient of hematology should get a proper diagnosis and a proper treatment. And that will be possible if we keep ourselves updated and a liking for the subject. So with these words, I would end my talk on this, and I would request Dr. Amit to take over the session, and I would be very glad to listen, Reena ma'am. Thank you.
Thank you, Dr. Priyanka, for that great words of wisdom. Let me share the screen again. It's now time to introduce our guest speaker for the day, Professor Dr. Reena Das from Chandigarh. Dr. Reena Das requires no formal introduction, but it's my duty to introduce her. She's Professor and Head, Department of Hematology at Postgraduate Institute of Medical Education and Research, PGI Chandigarh. Her field of interest are thalassemia and hemoglobinopathies, molecular genetics of non-malignant conditions, and prenatal diagnosis of hematological conditions. Her current research interest includes to categorize the molecular diagnosis of cases of undiagnosed anemias and bleeding disorders. And she has over 269 publications in her field of interest. She is going to lecture us today on uncommon hereditary anemias. And it's my privilege to invite you, ma'am, for this lecture, which we are really waiting for you. Thank you so much, ma'am, for being with us.
Thank you so much, Dr. Priyanka. It is my pleasure to be with you all and the entire group of the young hematologists who are budding hematologists in the field. I will just off my video so that I can concentrate on what I am speaking on. And so I will start with saying that anemias rarely is a disease by itself, and very typically they are classified into hereditary or acquired conditions. And I'll just dwell upon the hereditary conditions for this talk today. So we all understand that diagnosis requires a stepwise diagnostic algorithm to be followed, and the basic classification would be dependent on the reticulocyte preparation. So that will classify whether there is a hemolysis going on and whether it is an appropriate response, because our bone marrow has the capacity to step up its erythropoietic mechanism by about 6 to 8 times whenever anemia is encountered, considering that the anemias are not due to nutritional factors. So when it is hemolytic anemia, whereas there is increased destruction of the RBCs in the peripheral blood or in the spleen, we find that the patients will have a very typical clinical presentation of jaundice, which may be very early on, and cholelithiasis of the pigmented stone variant is also variety is seen. Splenomegaly is very common. We have seen many cases without having anemia, which means that compensatory mechanisms can sometimes override, and you can have a situation where the patient actually does not have anemia, but there is hemolysis which is going on. Then we have another set of problems which can occur when the bone marrow does not have a reticulocyte response, which we expect it to be there. And in these situations, we call it an inappropriate reticulocyte response, where the bone marrow examination is extremely important. These will include conditions such as sideroblastic anemias, congenital dyserythropoietic anemias, or pure red cell aplasias. Now, when we talk about the various disorders of the RBCs which are inherited, typically they are classified into 3 types. You could have the globin abnormalities, which are fairly common, I would say, and Dr. Priyanka did mention about the sickle cell and thalassemia disorders. These are very typically hypochromic and microcytic, and that can be seen. Then red cell membrane disorders, these are not very common, but typically they would present as spherocytic hemolytic anemias. And then you have the non-spherocytic hemolytic anemias, which comprise the enzymopathies. Now, for the hemoglobinopathies, we have a set protocol which is followed. We would like to do a hemoglobin HPLC to identify what is the abnormality. When we look at the HPLC and we find that there is an abnormal peak, we will always want to do a hemoglobin electrophoresis at an alkaline pH to start with, because that will give us the various types and of the combinations which may be encountered in such cases. When we think of hemoglobin H disorders, there we get a pre-integration peak, which are typically twin peaks that we see before 1 minute. And when we do a HBH inclusion preparation, we can see the golf ball appearance. And this is a picture which is showing a very high frequency of these HBH inclusions. Now, heat instability test is typically done when we are seeing hemolysis and we don't have any definitive diagnosis for unstable hemoglobin. We do the heat instability test, which is a simple test, and isopropanol solubility test is another one which is done. When we are looking for the beta globin mutations, very typically we look at the ARMS PCR, which was able to give us the mutations in most cases. And for alpha thalassemias, we do the multiplex gap PCRs. Now, Sanger sequencing is extremely important when we are encountering an uncommon variant, or sometimes we don't have the ARMS PCR primers or something like this. And usually we like to do Sanger sequencing when the lady usually comes very late and there is little time, when we would like to see what type of mutation is there. And here, this is a sequencing reaction, which is actually just showing us a frame shift mutation, where you can see multiple peaks over there, which is not just 1 peak or 2 peaks. And I'll be showing you some chromatograms as we go on to the cases very rapidly. For red cell membrane disorders, we see the spherocytes on the peripheral smear. We can see sometimes stomatocytes on the peripheral smear, reticulocytosis. Typically, we do an incubated osmotic fragility test where there is a shift to the right, and you can see the graph which shows that this is a increased incubated osmotic fragility test. Flow cytometric osmotic fragility test can be done whenever we have a flow cytometer with us. And this is a very easy test, because within a minute, you will come to see that the hemolysis is occurring quite rapidly in less than 1 minute. When we look at spherocytes in the peripheral blood, we also do the direct Coombs test, and this is an example of an autoimmune hemolytic anemia. When we are thinking about osmotic hereditary spherocytosis, very typically we do the flow cytometric eosin 5-maleimide assay, the dye binding test, and I'll show you examples of these. In a typical case, we really don't need to do a targeted next generation sequencing for a diagnosis, but it is advisable that whenever we are planning a splenectomy for the clinical symptoms of a requirement of blood transfusions, which may be going out of hand or out of proportion, at that time it's a good idea to do a targeted next generation sequencing so that we are able to pinpoint the molecular diagnosis. And I'll show you examples why we need to do it. Enzymopathies are typically very difficult to identify because you need specific labs who can actually identify. And in India, apart from the National Institute of Immunohematology, who are able to do some of the enzyme assays, apart from G6PD deficiencies, labs are not really equipped for doing these enzymopathy assays because these are difficult ones to standardize. For pyruvate kinase deficiency as well, there is a problem because many times the enzymes are raised in the RBCs simply because there is reticulocytosis when the patients are having an active bout of hemolysis. So usually we like to repeat the tests for enzymopathies whenever the tests come normal, and we do want to do the sequencing in many cases when we are diagnosing enzymopathies. Now, when we look at the peripheral smear, here you can see that there are some target cells, teardrop cells here. And here you can see some sickle cells, nucleated RBCs in the peripheral smear. This almost looks like a megaloblast in the peripheral blood. And you can see that these spherocytes, which look like spherocytes, are actually showing possibly some blister-like projections over here if you look at them very closely. Here again, you can see spherocytes, but apart from that, you also have acanthocytes, which can also be seen sometimes with cases of hereditary spherocytosis. These are like stomatocytes here, again stomatocytes with some giant platelets, again some lot of anisopoikilocytosis, which is not uncommon in red cell membrane disorders. Here you can see, apart from these poikilocytes which are there, again a dysplastic looking nucleated RBC in the peripheral blood circulation. And like I said, I give a lot of importance to the reticulocyte count, which I like to see manually, but nowadays we have instruments which can give you the red signal that we are looking at a hemolytic anemia much more rapidly. Now, I'll just touch upon the spectrum of thalassemia and hemoglobinopathies. I don't want to talk about these because these are common disorders. Mostly these are autosomal recessive disorders. We have populations where thalassemias and hemoglobinopathies coexist, and you have a high fetal hemoglobin in some patients, which we called as an inappropriate expression in adults, where you don't expect the fetal hemoglobin to be high because usually after 1 year of age, the fetal hemoglobin levels touch less than 1% in the peripheral blood. The unstable hemoglobins, the polycythemic variants, which are like gain of function mutations, or methemoglobinemia, where you have an unusual property of the RBCs. Where here in these conditions, these are usually sporadic hemoglobin variants or inherited as an autosomal dominant condition. So the family studies become extremely important. If you go to the database of the human hemoglobin variants and the thalassemia mutations, there are multiple of mutations which are there. Many of them are of these various categories where the alpha, delta, gamma, everything you can just find out how many variants are there. And this constantly keeps on getting updated. Now, the clinical phenotype is what is extremely important, and I give a lot of importance to the clinical phenotype. When my clinician tells me that it appears like that the phenotype is not matching, I always want to go ahead and try to solve the cases because that's where it gives you a lot of satisfaction. And when we are talking about hereditary hemolytic anemias or hemoglobinopathies or the congenital dyserythropoietic anemias, what is very important is parental screening. And I like to always keep the blood samples of even the children who are affected as well as the siblings who are unaffected, because many times their molecular pattern helps us to identify which mutation is the one which is pathogenic, especially if you're doing a targeted next generation sequencing or an exome sequencing. Now, very briefly, I'm talking about a case. This was a typical thalassemia intermedia clinical phenotype, I would say, because he was a 4 years male, showed pallor, frontal bossing, hepatosplenomegaly with very mild jaundice. There was no history of blood transfusion, and I would probably call it a case of a thalassemia intermedia, which looks to be mild or moderate thalassemia intermedia because the presentation is relatively early. The child had a hemoglobin of 8.6 grams percent, and the father was more or less normal, though there was some hypochromic microcytosis in both the parents. And you can see that the child, because of the splenomegaly, probably had the platelet counts, which was bordering to about 99,000. Now, when we looked at the child's HPLC, it typically looked like a thalassemia intermedia, where the fetal hemoglobin is extremely high of 96.1%. And in such a situation, all we want to do is parental screening. But if you look closely at the HPLC, you see that there is a twin peak over here. The HbA2 percentage, you can see, is reduced to 0.7% only. But this abnormal peak, which is there as an unknown 2.4%, looked kind of abnormal or atypical. When we looked at the father's HPLC, we found that the A2 is increased and the A2 peak is kind of broad-based with a slight hump here at the descending limb. And in such a condition, you have to think about hemoglobin Lepore, because this percentage of hemoglobin A2 neither fits with the beta thalassemia trait nor with a hemoglobin E trait. But when we have hemoglobin E trait with alpha thalassemias, sometimes the A2 percentage can be reduced than how it should be, of to roughly about 25% or so. Now, when we looked at the mother's mutation, we found that the mother was IVS15 and the father was positive for the hemoglobin Lepore because of this abnormal band which was there of 777 base pairs. And here, when we did the sequencing, we found that this was hemoglobin Hollandia. And this is a bit tricky for sequencing because there is a change which we can identify as delta. Just after the delta, it becomes a beta kind of variant, which comes because of the because of the molecular part, where you find that this part is kind of deleted, part of delta and part of beta. And such kind of fusions we need to keep in mind, or atypical cases of thalassemia intermedia, which need to be looked closely. Not a very common condition, and we possibly see about 1 or 2 cases in a couple of years or so. So if we talk about the genes which are associated with hereditary anemias and dyserythropoietic anemias, you can just see the list. And this is not a very comprehensive list because there was no space in the slide. And you can see that there are so many genes which are involved. So it becomes very difficult when the clinician tells us that, please let us know the diagnosis. And that is the reason why we say that it is probably best to straight away go to targeted next generation sequencing or an exome sequencing of the family members. Now, if you look at the genes that I showed you in the list, and I've tried to compile over here the various genes where this is the transcript sizes, which you can see. And the numbers which are given at the top here are the number of exons which are there. Now, the genetic studies based on Sanger sequencing would be very difficult because the number of genes are so many, the sizes are quite variable, and there are a lot of complexities while trying to do a gene by gene based sequencing methodology. So I'll come to straight away a case history. This was a 31 years male who was a known case of Gilbert syndrome, so which means that he was possibly having some jaundice with bicytopenia, which was possibly contributed partly due to the hepatosplenomegaly. On the ferritin evaluation, there was hyperferritinemia. And when we looked at the peripheral smear, you can see that there is a lot of hypochromic microcytosis. The RBC is reduced in number. You can see only 2.47 million. And the MCV, MCH are low. Now, when we looked at the RBC histogram, you can see that there is a hypochromic microcytic population and there is a kind of normocytic population also. So they were dimorphic red cells, and we went ahead and did the bone marrow, and you can see ring sideroblasts, which are there in this particular case to about 20%. And this is a siderocyte where the nucleus is not there, but you can see multiple siderotic granules. So when the next generation sequencing was done, it gave us a lead that this looks like an X-linked sideroblastic anemia in the ALAS2 gene. This was a known mutation. And when we see a known mutation, it becomes a little easier for us, especially when we're talking about missense, to talk about the pathogenicity. There were multiple reports in the literature for this particular variant to be there in multiple populations, in the Chinese, African Americans, etc. So this was a fairly straightforward case where we could say that this looks homozygous on the Sanger sequencing because it's an X-linked gene and there's only one X chromosome. So this male would be called as a hemizygous male with a pathogenic variant in this particular case. Now, congenital dyserythropoietic anemias, they are again where we don't find an appropriate reticulocyte response and a type of a rare Mendelian disorder where you have bone marrow failure kind of picture because of ineffective erythropoiesis, a lot of dyserythropoiesis, and it affects the normal differentiation proliferation pathway of the erythroid lineage, lot of genetic heterogeneity, and this is kind of trying to show you the classifications of which now we have so many different genes which are just getting added, and you can see some question marks are there where we don't even know the genes. So there is still scope of research in these kind of disease conditions, and all is not yet known. The commonest type of congenital dyserythropoietic anemia is the type 2-1, where the SEC23B gene is the causative or the mutated gene, and this is residing on the chromosome 20 short arm. Now, when we look at the bone marrow, these are the kind of changes we would like to see. And if we see good binuclearity or multinuclearity, then it becomes easy. But this is not a very common finding that we find. When we look at the peripheral smear, see a lot of dyserythropoiesis in the peripheral smear, and the reticulocyte response is inadequate. Finding nucleated RBCs which are dyserythropoietic, it gives a kind of a signal that possibly we are trying to think of a dyserythropoietic anemia. So these are the morphologies which we look at, and this is again ring sideroblast. Usually these patients also have iron overload, which could be contributed by the blood transfusions and the increased iron absorption, even if the patient is transfusion independent, similar to what we see in non-transfusion dependent thalassemia syndromes, where the patients keep on absorbing the iron from the gut. So this is a very typical case of a type 2 CDA, where you see these binucleated cells in the bone marrow, which have similar sizes. So when the pathologist sees this, they usually think of type 2 CDA, and that is many times accompanied by these Gaucher-like cells in the bone marrow because of the increased metabolism and high rate of turnover. So these would be called as pseudo-Gaucher cells by the pathologist. So electron microscopy is a good thing to do, where you will be able to see the peripheral cisterns. But nowadays, it is done in very few centers, and most of the time we do the flow cytometry by the eosin 5-maleimide. The type 2 CDA also shows reduced mean fluorescence of the ratio. So usually if we see a ratio which is less than 0.8, and if we see reticulocytosis, we think it is a hereditary spherocytosis. But when the reticulocytopenia is there relatively, then we think about type 2 CDA. So I think I'll just skip the molecular biology of CDA type 2, but there is, I just wanted to show this diagram where you can see that basically it is a cargo kind of a protein which is there. It is associated, the SEC23B is associated with SEC24B, and this just shows that this is just a subcomponent, really, of the endoplasmic reticulum and giving rise to congenital dyserythropoietic anemia. So you need all these molecules to be perfect to have a proper kind of erythropoiesis, which should happen in a normal individual. We have found in our population a single mutation, which is in exon 12 in the SEC23B, and most of our population, if they are Khatri Auroras, this particular mutation has been seen to be a recurring kind of a mutation. So if we see that morphology, then straight away we just do a Sanger sequencing to look for this mutation. If this mutation is absent in our population or in the index case, then only we take up the case for targeted next generation sequencing. So coming to the case history of a 9 months male, he was transfusion dependent and he had hemolytic anemia with reticulocytosis. There were about 30 nucleated RBCs, and this is the reticulocyte count of 16%. So there was severe anemia with patent ductus arteriosus. The patient also had neonatal morbidities with sepsis, cholestasis, respiratory distress. There was some thrombocytopenia with unconjugated hyperbilirubinemia. You can see that it was kind of variable bilirubin levels. Now, when we looked at the hemoglobin HPLC, which is the kind of the first thing that we do, we found that the fetal hemoglobin is increased. Now, this is again something that we see not very uncommonly, because when there is anemia and there is erythropoietic stress, you could get some increase in fetal hemoglobin. And here this child was actually receiving a lot of transfusions. So there again, you would expect that the fetal hemoglobin will be reduced because of these transfusions that the child is receiving. Now, the parents had normal red cell indices, and the hemoglobin HPLC was also normal, and rest of the hemolytic workup was also kind of normal. Now, when we did the sequencing of the targeted sequencing, it gave us a mutation in the KLF1 gene, which was sequenced by Sanger to identify a heterozygous variant by confirmation, and the parents were both negative. So we could call this as a type 4 CDA, which was a sporadic variant. Now, this type of CDA, usually there are just a handful of cases all over the world, and usually these children, they require a bone marrow transplantation. The child underwent a bone marrow transplantation in CMC Vellore and now is free of anemia. So this was kind of very satisfying, and you can see how the CDA is overlapping with the hemolytic anemia in this particular case. Another case where there was thrombocytopenia, where you can get GATA1 mutations, which is again X-linked in the short arm of X chromosome. And usually these are males who are affected. So this was a 5-year male. He had pallor, petechiae, ecchymosis, hemolytic facies, and hepatosplenomegaly. There were 2 brothers who were had the same kind of symptoms. And we had actually done the bone marrow for both the brothers. And we found that there was 15% dyserythropoiesis. And this case was kind of one of the pending cases that we had over the years. And when the targeted resequencing came up in the last decade or so, we happened to do the molecular analysis. And this is what I always say, that, the patients may come and go, but it's a good thing to keep the DNA, because we may not know something today, but something may come up later on in the course of our learning and understanding of diseases, and it really helps us to identify and also, think about new conditions which we come across, and I'll show you some more examples of these. So this was a GATA1 variant which was picked up on the targeted NGS. It should have been a G here, but you can see that it's a homozygous kind of T, which was shown by the Sanger sequencing as well in the exon 4 of GATA1. Now, what is very interesting about this particular mutation is that the mutations are more or less in GATA1 in this particular domain. And this is the N-terminal of zinc finger domain. And you can see that these various signs which are given as the star and triangle and all this just shows that this is the variation in the clinical phenotypes that we can get. Same mutation, same position, and many times you find that the patients have a various different kind of a presentation, which can even be something as innocuous as appearing like a beta thalassemia trait where the A2 appears to be increased, to something like a congenital erythropoietic porphyria with a clinical phenotype of thalassemia intermedia, to even fetal hydrops. So very interesting gene of the GATA1, because the protein itself is very important as a transcription factor for the normal erythropoiesis to take place. When we come to the inherited hemolytic anemias, we have these various types of disorders which are defects in the RBC membrane. Commonest, of course, is hereditary spherocytosis, which has a very typical presentation. Most of the times they are autosomal dominant, but you can get autosomal recessive mutations, and also the patients can be very severe as well. And you can see that there are various conditions which are written as RBC membrane disorders, so you can get unusual cases as well. If we talk about the other disorders, which are mostly enzyme disorders or pathway, the G6PD deficiency, of course, is the commonest, and the pyruvate kinase deficiency is the second commonest among these disorders. But you can see that other disorders can be there, which is why it is difficult to identify these. Just very briefly about the RBC membrane proteins, you can see that apart from hereditary spherocytosis, where the mutations can be in any of these genes, there are these dehydrated hereditary stomatocytosis, which are also associated with mutations in either the piezo or the KCNN4 proteins as well. These are all membrane proteins which are there. And in addition, you can get hereditary elliptocytosis or even hereditary pyropoikilocytosis with mutations which are traversing through multiple proteins in on the red cell membrane. So you can see red cell membrane itself is a storehouse of so many proteins, and I think we know very little about these proteins as well. And which is why over time we are getting more and more variants and mutations which are in the realm of these red cell membrane disorders. So typically we do the Yersin 5-maleimide test. Typically we should take 5 to 6 normal control samples each time that we are testing, which are kind of age-matched controls. And the test is a fairly simple test. If you have a flow cytometry cytometer, you can do this test very easily. And a red cell membrane analysis can have a multifaceted kind of variants or different types of tests which can be done. But nowadays, it is not really important to do so many of these tests. And the molecular analysis is actually required only when you're trying to think about doing a splenectomy, or else in an atypical kind of a case, it can happen. And this is one example here. If we got a splicing mutation where the entire exon had kind of got deleted. Now, these are the two PhD scholars who did their PhD with us, and they were very crucial in doing this work, which we were able to publish in the British Journal of Hematology. You can see that there are various types of mutations which can happen in the SPTB gene or the ANK1 gene. And when we analyzed, we found that in our study, only 53% of the mutations were there in ANK1. But you can see among the various populations, like the band 3 mutations are quite common in the Western studies, but not so much in our Indian studies. So coming to the case history of another case, here this patient was a young adult. His hemoglobin was fine and he had compensated reticulocytosis, and there was no positive family history. A lot of stomatocytes in the peripheral blood, and the reticulocytosis very overwhelming. We happened to do the scanning electron microscope, and we found that there were these cup-shaped erythrocytes which was there. We took it up for targeted next generation sequencing, and this is just to show the bioinformatic pipelines that we follow, where you can find so many variants which are there, and they have to be, removed by one after the other, step-by-step manner, and we came across three variants which could have been pathogenic. Now, how do we go about this kind of situation? We find these three mutations all missense, and that is the most toughest part of trying to identify which may be the pathogenic mutation. So we take help of the bioinformatic tools. This says that this is a deleterious mutation. So we take help of the parental screening. The mother did not show the mutation. Father showed the variant. Father was asymptomatic. So we said, oh, this is not the mutation which is pathogenic. Then we had these other two mutations. One of them looked like a neutral variant on the RAG gene exon 3, and another looked more likely to be pathogenic. So we went ahead and did the Sanger sequencing, and we found that this variant is present in the mother and the index case. Again, mother is asymptomatic. So we said, no, this is not the case which is pathogenic in this particular individual. So we ended up with doing the Sanger sequencing of the third mutation, and we found that this is the index case where the mutations are missing in the mother, father, as well as the brother, and this looks to be the pathogenic mutation. On doing the PCR RFLP in the population, we found that it was not found in the normals, and then the PhD student, actually, when she was looking and studying, she found that this RAG gene and the RAG protein was associated with CD47, which is on the red cell membrane. So we got hold of the CD47 antibody and then did a flow cytometry on the red cells, and we found that this patient had almost half the fluorescence which was there as compared to the control. And this showed that this is the mutation which was kind of the pathogenic variant. So sometimes, we have to take help of multiple techniques to get across and find what is the mutation. Pyruvate kinase is notorious because they can have a very wide range of clinical presentation, and it can range from hydrops fetalis to a neonatal jaundice with multiple exchange transfusions, and many patients have really improved with splenectomy also, which was usually done. And nowadays, of course, one doesn't like to do splenectomy for such conditions. Now, there is a problem when we try to do the assay, because the leukocytes or the WBCs, they have a very high activity of pyruvate kinase. And whenever we are doing the test in the lab, we need to remove these leukocytes before we are able to do the red cell pyruvate kinase enzyme activity. This particular child was a 4-month child, and he had neonatal jaundice, had double volume exchange transfusions, and the mother did not have any problem. This child had some red maculopapular rash and required blood transfusions with hepatosplenomegaly. Now, you can see very severe anemia was persistent in this patient. The reticulocyte count corrected was also a little variable. And I also want to highlight that sometimes the reticulocyte count can be suppressed in hemolytic anemias because of these multiple transfusions which are given to the child. So it's important to look at the reticulocyte preparations multiple times before we can really say that this is a hyperproliferative erythropoiesis or not. So we had done the bone marrow examination because there were some nucleated RBCs in the peripheral blood. There was some degree of disc erythropoiesis in the bone marrow, but to our surprise, we found that this patient actually showed 2 mutations on the PKLR gene. So this case kind of highlights that occasionally you can get reduced reticulocyte response in cases of pyruvate kinase deficiency, which is typically a hemolytic anemia. Then another child was referred to our department, and this was a Bengali female child, was from a non-consanguineous marriage and had neonatal jaundice. All we found in the peripheral smear were a lot of these acanthocytes and some spherocytes in the peripheral blood, and reticulocytosis as well. And I had thought that let's do the PKLR gene because the mutations are more commonly found in the pyruvate kinase with this kind of early presentation. But when we did the next generation sequencing, we found that there's a germline pathogenic variant, which is due to the glucose phosphate isomerase deficiency. This was the first time that we were identifying this particular gene to be associated. Now, of course, there are a lot of variants which have been found in India because of the sequencing which is being done. This was homozygous. The parents were not aware that there was a problem, and we could offer prenatal diagnosis in such a situation where the mutation is there. Now here, this was identified from our center for the first time. And like I said, now many cases have been identified from India. This particular mutation was at an important position of the arginine 346 because the two dimers of the glucose phosphate isomerase, the mutation happens there because this is the normal kind of position, and you can see that when it becomes a histidine, this becomes the structure becomes abnormal. So this was a GPI deficiency. Another case, a male 10-month-old child had a lot of spherocytes, lot of Gabo rings, basophilic stippling, nucleated RBCs which were there. And the next generation sequencing actually showed that this was there was a mutation which we were not able to really pick up by the first time when we did the sequencing. This was picked up when we did the exome sequencing. And then when we went back and found that why did we miss it in the targeted sequencing, we found that occasionally we have these particular variants or which are there. The hexokinase 1 enzyme is a very notorious enzyme because there are multiple isoforms. So when the targeted next generation sequencing was done, it was annotated to the first transcript which comes up on the sequencing kind of on the gene annotation. But when actually we did the exome sequencing later on, we found that the isoform which was actually looked for was not the correct isoform when the nomenclature was done. So I just put up this case to show that because some of these enzymes can also be having multiple isoforms, it's important that which mutation we are calling it as pathogenic is may actually appear in the intronic position. Like earlier when we had done the nomenclature, we found that this position was an intronic position, and then we thought that it is deep inside the intron. So obviously this is not a pathogenic one. But when we looked at the sequence, which was the important sequence for the erythroid gene, erythroid enzyme isoform, we found that this was actually a stop codon which was there, arginine to a stop codon. So this case kind of highlighted to us that even if you do the sequencing, and even if you do a targeted next generation sequencing or exome sequencing, these cases can have a problem because of the multiple isoforms. And it's important that the correct isoform is analyzed when we are looking at the variants which are there. So we are constantly learning, I think, from our cases, and it just shows that we have to keep on evolving as we grow by. Another case, this was again a very nice case because this was diagnosed as a case of hereditary spherocytosis, and the earlier generation hematologists would remember Dr. Marvaha, and Dr. Marvaha's own handwriting records were available with the patient's mother. She had the history of this child's all hemograms very nicely catalogued. And there was this incubated osmotic fragility test, which was positive in the index case and the sister. The sister was also being evaluated for Turner syndrome with streak ovaries. And this particular time, the clinicians, they actually sent the case to us that, ma'am, this EMA dye test was not available earlier, so why don't we just do it? Both the sister and the brother, they seem to be having various kinds of symptoms and various stages. So there was a pleiotropic type of presentation apart from that hemolytic anemia, which was a subtle hemolytic anemia which was ongoing. When I looked at the smear, I found that there were multiple stomatocytes. You can see almost like 70% of the RBCs are not spherocytes, but they are stomatocytes. And there was these giant platelets also. So I did the best thing that we have now learned, Google. And when we Googled, we found that the condition of stomatocytes with these giant platelets, this is called as this stomatocytic hemolysis as Mediterranean stomatocytosis. This was kind of not known. And you can see that over time, this patient had undergone a bone marrow also for megakaryocytic thrombocytopenia, because our earlier counters, which were impedance based, would just say thrombocytopenia. So unless a good smear examination is done, the sometimes we get waylaid, and this case is a typical case where this kind of thing happened. So what is this condition of Mediterranean stomatocytosis? Here there are two genes which are involved, the ABCG5 or ABCG8, and these two genes have a mutation which gives rise to the manifestations of having these two proteins actually, where the sterolin which is there is involved in eliminating the plant sterols normally, which are not to be used by the human cells. But because of the mutations, we keep on absorbing these sterols in the, like this is not what normally should happen. So here the particular mutation was there, the 243 base pair mutation, which has been described. And this is a condition where rare recessively inherited metabolic condition where absorption of sterols, both cholesterol and plant-derived phytosterol, is not only unselective, it is also uncontrolled. Nowadays, you also have a drug which is available, which is known as ezetimibe, and it has received US FDA approval. So at least there are some drugs involved, because sometimes these patients can also have premature cardiac death. So these patients need to be under these drugs, and this is not a very costly medication, fortunately. Another case, which was again a very learning experience, and this is the last case that I'm showing. Here, this case was diagnosed as a hereditary hemochromatosis in 1992. There was no positive family history, ferritin was increased, and the liver biopsy was suggestive of hereditary hemochromatosis. This patient was on regular phlebotomies for so many years, and because of this generalized weakness and easy fatigability, hyperpigmentation, as well as splenomegaly, DNA analysis had been done for these common genes implicated for hereditary hemochromatosis, and it was found to be kind of normal. Now, a few years back, this patient came to the OPD, and the clinicians were very astute, and they said that there is some hemolysis which is going on. Now, that looked very odd to me. By then, this patient was about 66 years male, and when I looked at the peripheral smear, I found that the RBC is less because the hemoglobin was on the lower side. It was quite severe anemia which was there. Retic count was increased here. You can see the reticulocytes. These NRBCs were there, some stomatocytes, but nothing very significant in the peripheral smear. So these are not very good smears. Some very dirty smears are there, and you can see that some stomatocytes are also there. Now, when the next generation sequencing was done, to our surprise, we found a mutation in the PISO1. And this particular mutation had been described in the first case, which was diagnosed worldwide. Now, this PISO gene, I had shown you on the PISO protein on the red cell membrane. This was validated by Sanger sequencing. And this turned out to be hereditary xerocytosis, usually have compensated hemolysis, and don't require transfusions. But what was happening in our particular case was this dehydrated stomatocytosis was masquerading as hereditary hemochromatosis. Now, this particular protein was identified only in 2010. And you can see that our case actually came presented in 1992. So even before we knew about this PISO gene, PISO protein mutations, and this person, Dr. Erdem, he happened to get the Nobel Prize for this, his discovery of the PISO family of the proteins which are there. So we have encountered now cases of inherited stomatocytic syndromes due to various conditions. It can be autosomal recessive or it can be autosomal dominant. And typically in hereditary xerocytosis, there is increased MCHC. So if you get a mild to moderate hemolytic anemia and a very high MCHC, your antenna should go up that this might be a case of hereditary xerocytosis. So there are certain limitations of next generation sequencing because you may be able to solve some cases with sequencing. And in our experience, actually, among the hemolytic anemias of these remnant cases which were there, when we did the exome sequencing, out of 10 cases, we could actually identify only one cases, the case I showed you of the hexokinase deficiency. So there are therapeutic implications because the correct diagnosis, splenectomy, is indicated in some conditions, but may not be there for other conditions. In cases of overhydrated hereditary stomatocytosis, it's advised not to perform splenectomy because there can be increased thromboembolism. You can change the therapy if it is Mediterranean stomatocytosis. We had a case of MTRR deficiency where a high dose of hydroxycobalamin can give rise to amelioration of the symptoms. Prenatal diagnosis can be offered in serious conditions of CDA type 2 or hexokinase deficiency. And nowadays, in the West, people are giving this drug, the enzyme activator AG348 for pyruvate kinase. Unfortunately, the trial is not yet there in India, but the West has shown a very good response for pyruvate kinase with this particular drug. So the take-home message is that hereditary anemia diagnosis, it requires a stepwise diagnostic algorithm to be followed. Clinical manifestations can be overlapping. Phenotypes can vary from patient to patient, and you can get overlapping features between hemolytic anemia and congenital dyserythropoietic anemia, especially when the patient requires multiple transfusions. I give a lot of importance to the family study to prove the pathogenicity. And of course, targeted sequencing is important because it can expedite the molecular diagnosis in various conditions. Unfortunately, this is the scene that is of our OPD blood collection center. This is a typical hospital picture where you will find our patients are so poor that we feel guilty that when we say that, okay, this sequencing is going to be so expensive. So life is a great leveler. One has to celebrate the imperfections of life. And I would like to end by thanking my institution, which has helped me to do all this work. And also I have an excellent team of faculty colleagues as well as the technical staff who are there. And a lot of work has actually been taught to us by the NIBMG group in Kalyani. And I would like to take up questions by thanking all of you for your patience. Thank you.
Thank you so much, ma'am, for that wonderful lecture. It was really fabulous. What an eye-opening for all of us. Many new things we learned regarding the hexokinase deficiency, again, that stomatocytosis with thrombocytopenia. Superb, ma'am. That was really a great learning. So we will have the discussions now with our discussants. So I request all our discussants to please have a raise hand sign first.
Yeah, hello, madam. It was a very excellent sharing of cases, which we hardly get to see, even though we are practicing in hematology. So thanks a lot for sharing your cases. I just want to know, like, when diagnosis familial spherocytosis, who's presented at a very early age, and splenectomy is the one condition which helps them. So should we go ahead with splenectomy at an earlier age because then they become transfusion free?
So, Deepak Bansal and Dr. Amita Trehan, who are the clinical pediatricians with us, they usually advise a partial splenectomy at an early age. And we've got good response with that. But because it's autosomal recessive condition, I think it may be a good idea to probably have the molecular diagnosis before undergoing a splenectomy.
That too, after doing that, I'm asking whether splenectomy should be advised.
patients show a good response is what I know, but I'm not a clinician. But I know that a lot of patients actually benefit with splenectomy, especially with symptomatic hereditary spherocytosis.
Yeah. So I'm very much impressed with your method of bioarithmetic analysis, which systematically diagnoses of the genetic defect. Huh?
I would like to admit that, I've shown you cases which are good cases, but there is a horde of cases still unsolved in our kitty. So that is the usual thing that we get in practice, that, not all cases are solved. And hopefully over time we'll learn from them and solve the cases as time goes by.
And one last thing, for hereditary xerocytosis, which was masquerading as hereditary hemochromatosis. So initially he was treated with phlebotomies, right? So how do we explain that initial treatment which has helped him?
Yeah, so when we were actually publishing this case at that time, this was the query which was raised, that, sometimes what happens is that the patient goes to a particular clinic, and here the patient went to the hepatologist. So when he went to the hepatologist, at that time, the hemoglobin was not so low. And so at that time, I think the liver biopsy was done, and the liver biopsy showed iron to be there in the parenchyma. And the label went on as hereditary hemochromatosis in this patient. And the patient never came up for follow-ups that frequently, because he was getting these phlebotomies done in a private center in his home place. So it was only last, I think, probably 5 years back, when he came on follow-up. At that particular time, the clinician told us that, I think that this patient is anemic, and please have a look at the peripheral smear and the reticulocyte count. And actually, there was at that time moderate anemia which was there.
Thank you so much, ma'am. Dr. Sujata, ma'am. Dr. Jagdish Chandra, your question, please.
Hi, Dr. Reena Das. It was really a very wonderful talk. As usual, I have heard you a number of times. And in fact, we had an opportunity to work together for action on birth defects of Uttarakhand. At some point of time, we worked for the module development for thalassemia management in Uttarakhand. So a very wonderful talk, and really learning how to, approach. And we have at times discussed also certain cases. Um, uh, just to highlight a couple of things, not a great question that I have, but the highlight certain things. As you said, going stepwise, that is something very important, and we have to realize that the nuances of the PS reporting, that the younger colleagues have to pick up, that what the clinician is trying, what the pathologist is trying to say by presence of one particular type of cells or few cells of that type, even that at times becomes important, and that probably gives clues for the diagnosis. And sometimes there could be overlap of the things, like you showed cases where CDA and hemolytic picture that was overlapping. So presence of jaundice.
Sir, you were actually, you're muted, sir. Yeah, we lost
Am
you.
I audible now?
Yeah, you are audible now. Please go
Okay.
ahead.
Yeah, there might have been some problem in the net. Okay, all right. So I was just highlighting, it was a wonderful talk by Dr. Das, and obviously learning from the cases that you presented. That was something great. Um, I just wanted to highlight certain things, like what she said, going by the clues that you get in the peripheral smear examination. And for us clinicians, as well as particularly the junior level clinicians, it's very important to realize that what the hematopathologist is writing by presence of few cells of this type and few cells of that type, that does have a lot of meaning. And going by that, you pick up and try to find out what the diagnosis could be, and obviously correlating clinical and things. One comment which the previous speaker asked about the splenectomy, I think it's very important to realize that splenectomy these days is it's avoided because of the complication. Dr. Das also said that in some particular conditions, she mentioned that there is a lot of thromboembolic phenomena after splenectomy. In fact, thrombotic episodes do occur with splenectomy being done for any type of disease. In thalassemia, this has become rare now. And even in hereditary spherocytosis, there is now trend that you manage till 5 to 6 years of age, manage like transfusion dependent anemia, and then think of splenectomy, and that, as she said, that going by partial splenectomy only. So these were the comments that I wanted to make. Thank you.
Thank you, Dr. Jagdish sir. Dr. Abhilasha, your question, please.
Excellent talk, madam. Learned a lot from it. I have a question regarding the role of mitapivat, which you mentioned in pyruvate kinase deficiency. So I have a cohort of around 20 patients of GPI deficiency. So I was wondering if the same drug would be useful in this enzyme deficiency also, because although this drug is basically a pyruvate kinase activator, but at the same time, it increases the RBC ATP levels and reduces the 2,3 DPG levels. So any trials or any experience on that?
So I had gone for a thalassemia conference recently, and there actually they were talking about even using it for thalassemias for increasing. So in multiple enzyme deficiencies, they're actually trying it out as a trial. But when I was asking about whether to get it to India, there was a very strange response that I got from the drug company. They said, and there were some Indians who were there. They said that they are not getting it to India because very rapidly Indians make a very, they make a Indian variant of the drug very easily. The pharmacology that seemed to be the reason why they're not.
Mutations in the drug industry.
That was, I said, there are so many patients actually in India. And there was one patient actually through Dr. Deepak Bansal, he contacted and he was very keen to start the drug, but they said that they will not send the drug to India, at least when the trial is on. So I think the world literature will come out. I think this drug is showing a good response.
Can I ask one more question?
Sure.
So I have a case of dehydrated form of hereditary stomatocytosis. Now this child, he's currently 15 years old. He has severe iron deficiency, and to the extent that he requires monthly parenteral iron infusions. Now we have done the GI workup. We have not picked up his endoscopy, biopsy, everything has been done, and it's normal. There's nothing suggestive of blood loss. So are you aware of any coexistence of iron metabolic defects with these membrane defects?
Yeah, so yes, these PISO mutations, they're also kind of very notorious because depending on the type of mutation which is there, many patients are going to be, many subjects, I will say, may remain asymptomatic. So this iron overload that we see is typically, it happens when there is anemia. So the gut really doesn't know what is the cause of anemia, and the iron keeps on getting absorbed as a non-specific kind of a mechanism. But usually if the hemoglobin is fine, nothing needs to be done. And I think this might be just a red herring. This mutation that you've got might not be actually giving rise to too much of clinical symptoms. That's why you are having to actually give iron to your particular patient.
Thank you, ma'am. And I would like to share a case of adenylate kinase deficiency. I have a lot of these enzyme deficiencies because in North Karnataka, consanguinity is very common. And so we get a lot of these enzyme deficiencies. So adenylate kinase deficiency, this child was diagnosed when he was 6 months old. And he was requiring very frequent transfusion, almost once in 20 days. And he had hypersplenism, a lot of complications. So we had to go for splenectomy at the age of 3 years. And it's been 2.5 years and the child has not required transfusion. So splenectomy can really be helpful in these cases. Yeah. Thank you.
Yeah, thank you, Dr. Abhilasha, for that wonderful update. We have a question in the chat box. Dr. Bilal wants to ask that if you get echinocytes in the peripheral smear, and reticulocytes counts are raised, can this be a clue to pyruvate kinase deficiency straight away?
No, I don't think so, because a lot of these cell changes can be non-specific. If you get a lot of acanthocytes and you get some spherocytes, we have seen this kind of combination with hereditary spherocytosis, where you get alpha spectrin or a beta spectrin variant also. But you're right, if the patient presents very early, I'll say less than 1 year of age, requiring transfusions, neonatal jaundice is, I think, quite common in these kind of conditions, then thinking of pyruvate kinase as the first choice would be, I think, a correct decision. But unless we are able to prove, I think it's difficult to say whether this is going to be.
True, ma'am. Anybody has any other question? Yeah. Yes.
Sir, can I ask a question?
Yes, please go ahead.
Hello, ma'am. It was an excellent talk. So I just have a question is that, as you said that there is a differential increased risk of thrombosis in different red cell membrane disorders, especially after splenectomy. My question is that, is it only because of this structural abnormalities of these red cells that has to do with it, or is it that because of some structural abnormalities of these platelets also in these disorders, like you said, macrothrombocytopenia in some cases, which also contributes?
No, I don't think unless there is sometimes we do get increased platelet counts with after splenectomy, but it's usually the red cell membrane abnormalities which actually give rise to this problem of thrombosis, because of these sphingomyelins, and I don't remember those various proteins which are there which help in this flip flop and things like that. And the RBC membrane also becomes thrombogenic, kind of, it becomes a thrombogenic surface in these conditions. And you would remember that even in thalassemia intermedia syndromes, thromboembolism, especially in some populations, have been described quite a lot. And I think if we look at our own cohort also, if you get a lot of anisopoikilocytosis, sometimes the patients are prone for thrombosis. So I don't think the platelets have so much to do with it as much as the red cell membrane abnormality in these red cell disorders, which give rise to thrombosis post-splenectomy.
Right, ma'am. Thank you.
Thank you, Dr. Urmila, ma'am. One question has come from the audience. Dr. Savitri Singh wants to ask that what is exactly the difference between echinocytes and acanthocytes on the peripheral sphere, echinocytes, acanthocytes, and the Burr cells, and how do you differentiate each of them?
Okay, so when the pathologist, when they look at the slide and they see that these spines are uniform, then we call it echinocyte. And when these the spikes which are there on the red cell membrane, they are not uniform, then we call it acanthocytes. So usually we try to think that if it is uniform, probably associated more with liver disorders. When they are not uniform, they're usually associated with kidney disorders. But it's not really very, very specific, I would say. Yeah.
It becomes sometimes very difficult to differentiate all this. Dr. Priyanka Samal, your question, please.
Thank you, ma'am, for that wonderful talk. Just wanted to ask, when we come across a patient or a child whom we are suspecting as a congenital hemolytic disorder, we do not have these all sorts of facilities available with us. Which would be the best way to ask this patient to go about having a test? The whole clinical exome sequencing for hereditary hemolytic anemias, or would it be like first the membranopathies have to be excluded or enzymopathies have to be excluded and then we go about it? Because phenotypically they almost express in the same way.
Yeah, so what I showed you is a diagnostic algorithm which we follow, in the sense that you keep on doing the test one after the other, exclude conditions. Now, the world is going very rapidly to a situation where you say, okay, there is hemolysis, looks like a hereditary condition. Why not straight away do a sequencing? It could be a targeted sequencing, or it could be a clinical exome sequencing, but that is becoming kind of the norm. in certain parts of the world. But so you find something and then you do the appropriate tests for those. That could be one approach. If you have sequencing facilities or labs which don't have the other tests which can be easily done. But it also depends on the pocket of the patient many times when we are asking for investigations. But this is becoming one of the trends for hemolytic anemias as well as for coagulation factor deficiencies, where you have a patient who's bleeding and you don't know, what factor deficiency may be there. You don't know where to send the patient for these tests. Then straight away people also do this kind of approach.
Thank you, ma'am.
Thank you, Dr. Priyanka. Dr. Kunal, your question, please. Yeah, Dr. Kunal.
Thank you, ma'am. Thank you, ma'am, for the wonderful lecture. My question is in continuum with Dr. Priyanka's question. In what cohort of the patients do you go for or do you choose for upfront NGS?
Upfront, yes, we
Or
choose
genetic testing? Yes.
upfront. We usually don't do, because ours is, you can say, a center where we have the other tests which are there. Um, uh, but that battery of tests is not too many. You've done your HPLCs, haven't found anything. Then you've done your, the EMA flow cytometry, haven't found anything. You've done your G6PD screening, haven't found anything. So then you are kind of stuck. You really don't know what to do. So in this situation, straight away, just go for sequencing, I think. We initially did it like this PhD project only. So we got a DBT grant, and when you have a grant, the good thing is that the patient doesn't have to pay. So, but the only problem is that you cannot ensure that you can give a report in a time frame, which is a patient care kind of time frame. That is the difficulty. So unless it comes into the public sector as a test or investigation where you can get the reports rapidly, the patient benefit or the answer to the patient is really not very easy. So we do get referrals from other places and we tell them it will take a little time before we can. And you get, even after you've done the sequencing, you'll get about 40-50% cases where straight away you can find the gene and the mutation and you can say, oh, this is pathogenic. But there'll be a good number of cases where you have to keep on going back and forth with your sequencing data before you can get hold of a gene of your interest. And I think I tried to show a couple of cases like those also.
Yes, ma'am. Okay.
Thank you, Dr. Kunal. Dr. Akshay, you have another question?
Thank you, sir. Thank you, ma'am, for the wonderful talk. Ma'am, my question is regarding few new research parameters. There have been few studies which has emphasized on the importance of MSCV, mean spherical corpusculum volume, and HDW, the hemoglobin distribution width, the ratio between RDW, HDW, and the difference between MRV and MSCV for differentiating these conditions. Ma'am, do you find them practically important and do you report these parameters?
So many of them are still research parameters only. So people who have done research mode kind of analysis have found them to be useful. In regular practice, what happens is that we don't look at those parameters, unfortunately, very diligently as we should. So usually, these peripheral smears are being looked at by the junior residents who are kind of trainee residents, or in some places even lab technicians also maybe. So the due respect is not given to these parameters, I will say, but they have been found to be very useful, at least in whatever literature we have. But most of the time I have to admit, we don't really look at them very closely.
Okay.
Thank you, ma'am. Thank you so much, Dr. Akshay. Dr. Abhilasha, your question, please. Dr. Abhilasha, do you have a question? Oh, I think she's Dr. Abhilasha. Are you there? Okay, I have a question, ma'am. Regarding we have got a case of hereditary spherocytosis, then eleptocytosis, ovelocytosis, pyropoikilocytosis. So based on MCF value, how can we differentiate all these three?
I wouldn't know that because I don't look at them very
Because you said less than 0.8 can be for hereditary spherocytosis,
Oh,
MCF.
so that MC, yeah. So you're talking about the flow cytometry. So
Yeah.
flow cytometry, some of the conditions can be easily made out, like the HS. I think HS, a typical case, we don't have a problem. But you would have seen, if you look at your spectrum of reports that you have with you, you will find that spherocytes are there in multiple conditions. Spherocytes by themselves will be written. Now, whether these spherocytes are the predominant finding or findings by the way is what we need to differentiate. So a case of hereditary spherocytosis usually has that antecedent history. That's why we say appropriate clinical setting is also important before saying that this is looking like a spherocytosis. Spherocytosis by themselves, I think I would say maybe 70-80% of the cases we don't have a difficulty on the smear. We look at the smear and we can say this looks like a case of hereditary spherocytosis. But those 20-30% of cases there can be a problem. And usually in hereditary pyropoikilocytosis, that itself is a very rare disorder, very rare condition, I think so. So there again the MCF can be reduced. We can find reduction in them as well. But majority of your incubated osmotic fragility tests will give you a variable result, because if you get microcytosis, then the shift is not towards the right, it shifts to the left. So you can have situations where you have red cell membrane abnormalities, but your osmotic fragility test is not really helping you so much.
Okay, thank you, ma'am. Dr. Hamza Dalal, your question, please. Yeah, Dr. Hamza.
Yeah, so thank you for the wonderful lecture, madam. Madam, I wanted to ask you, how do you do genetic counseling for women with hereditary anemia in the childbearing age who are about to get pregnant?
Fortunately, I don't have to do the genetic counseling. My clinician does it for me.
Okay.
It's a
So,
tough job.
yeah.
It's a job, especially if it is an X-linked disorder. I think it's easier to say when it is an autosomal recessive condition. Both the parents are, have to take responsibility. But autosomal dominant conditions are usually a positive family history is there in the family. So there you will find either the mother is also affected or the father is affected. And there they kind of know that there is a problem in the family, familial kind of a situation. But yeah, genetic counseling can be tricky in X-linked disorders. Just like this.
Any unusual complications that we can expect during pregnancy for these patients?
Maybe it's thrombosis, but I really haven't come across any difficulty.
Okay. Thank you so much, madam.
Thank you, Dr. Hamza. One question has come up from the audience. Dr. Jainara is there. She is an assistant professor at one of the universities. I think she is saying that, asking a question that if the child has undergone thalassemia transplant, in a case of thalassemia major, have you come across any situation where the thalassemia major has recurred again after the transplant?
Yes, of course. And I think the counseling itself you all will be doing, I think at that time you do say that there is a chance that there could be a graft failure. It's not unusual.
Thank you so much, ma'am. Any discussion has any other question for ma'am? So I think there are no other questions. And I think it was an excellent lecture, ma'am. What a wonderful update. Got to learn so many new things from you regarding hereditary anemias. And it was eye-opener was that thrombocytopenia with hereditary stomatocytosis and macrothrombocytopenia that you said. That was really wonderful. Superb lecture, fabulous, fantastic. Always wonderful to hear from you, ma'am. Thank you so much for giving us the lecture.
Thank you for the opportunity.
Thanks a lot.
Thank you so much. Bye-bye.
Bye, ma'am.